Thank you, Jenny. And good evening, everyone, and thank you for joining us tonight. The Specialised Team for Intellectual Disability Sydney and the Special Team for Intellectual Disability in South Eastern Sydney take great pleasure in bringing this presentation to you this evening. We do consider that the general practice and primary health networks are centrally important in improving the health of people with intellectual disability, and our teams have been set up to provide some specialist support to the mainstream health sector and to the primary health network. Tonight's session is talking about some key issues for adolescence and early adult life. We'll be touching on some areas that I'm sure you found challenging in your clinical practice and for which parents and young adults and children will be approaching you for support, advice and management. I would like to introduce to you first of all Dr. Adrian Keller, who's a Senior Staff Specialist and Intellectual Disability Psychiatrist in the Specialised Intellectual Disability Health Team in South Eastern Sydney, and he will be speaking to you about mental health concerns through adolescence. Philippa Cook, Social Worker on the Strides team with me, will be speaking about identity, a key ask of adolescence for which specific issues arise for young people with intellectual disability. And I will be speaking about a couple of different issues for adolescents: menstruation, I'll touch on sexuality, and then conclude with some important points around the formalised process of transition. Can I remind you, first of all, please, to submit your questions by typing them in the tab on your screen. We'll have a short period of time to answer questions at the end of each presentation, and then further time at the end of the sessions. If you're having any difficulty with the audio or video, please check your settings and connection. At the end of the session, you will receive a link via email to the online evaluation form. Once you've completed this, you will receive a certificate of attendance. We really do appreciate you joining with us tonight to discuss some issues that are essentially important for young people and their families with intellectual disability. So over to you, Adrian, to speak about mental health challenges in adolescents and young people. Thank you.
Thank you, Jackie. All right, and good evening to everyone. I hope that you have a stimulating session over the next hour and a half. So I'm going to talk to you for about half an hour. As you can see from the first slide, I'll be talking about mental health challenges in adolescents and young people being up to around about the age of 25 or 30. So we can move on to the next slide. Thank you, Jenny. So first of all, I'm just going to cover what is intellectual disability, just to refresh our memories. So it is a permanent impairment of general mental abilities that impact on domains of adaptive functioning. So the important things there are that it's permanent and it's global, and it impacts on a range of different functionings. Its onset is usually in the perinatal or infant period, but it can be any time before the age of 18, but usually it's much earlier than that. It does require very careful assessment, usually by neuropsychology specialists, to establish the presence of intellectual disability and the degree. So of course we know it can be mild, moderate, severe or profound, and as we'll hear later, the majority of people are actually in the milder end of intellectual disability, but of course it can be anywhere along that spectrum. And once established, the level tends to be stable, so people generally don't change their level of intellectual disability once it's been well established. But the capacity for ongoing learning within the constraints of their neurodevelopmental problems is usually maintained, so people can still continue to learn. It's not a static impairment that prevents ongoing learning. Next slide, please. So the intellectual disability is best conceptualised as a form of disability, a level of functioning that requires a specified level of support in a range of domains. So although it's associated with health problems, in itself it's a disability rather than a health problem. And we therefore think about the multiple clinical problems faced by people as comorbidities. And each of these comorbidities is by no means inevitable, but are quite frequent. And I'll be talking mainly about the mental health comorbidities that are associated with intellectual disability, and in particular in young people. Next slide, please. So psychiatric comorbidities, you can see here by the size of the font that anxiety is actually the most common anxiety disorders are the most common disorders that are comorbid with intellectual disability, and I'll talk about that in a bit more detail. Other disorders are also observed, but probably not to the same extent. So we do see depression and bipolar mood disorders, as we would see in the general community, but not necessarily to much greater degrees than in the general community. Psychosis similarly is common and certainly is increased in prevalence than in the general community. Self-injurious behaviour and aggression is really quite common in this population, and probably as you go through the spectrum to more moderate and severe intellectual disability, things like self-injurious behaviour becomes much more common. Aggression can occur at any level of intellectual disability and is often associated with other disabilities like ADHD and autism, which we'll come to. Ritualistic behaviours often mimic or resemble OCD, but rarely is it the true OCD that we see in people without an intellectual disability. However, some of the treatments we use are not dissimilar. For example, some of the medications we prescribe can be similar to what we would prescribe in persons with OCD. Next slide, please. So some of the neurodevelopmental disorders which could be considered within the purview of psychiatrists and mental health clinicians include ADHD, which I've already mentioned, which is very common in persons with intellectual disability. Obviously, specific learning disorders, which can include particular academic disorders in the realm of reading, maths, spelling, etc., particularly in people with milder intellectual disability. We often see oppositional, defiant, and conduct disorders, particularly in, again, the milder intellectual disability, which clearly disrupts learning and disrupts participation in social activities. And again, I've highlighted autism spectrum disorders as a particular comorbidity, which is prevalent not only in people with an intellectual disability, but of course it can occur in people without intellectual disability. But nonetheless, it's a very important neurodevelopmental disorder that can lead people with or without intellectual disability to require specialised services and indeed be streamed into other programs outside of mainstream services. Next slide, please. So I wanted to talk a bit more about autism in detail because, of course, it is a disorder that by definition will originate in early life. It's not a disorder that can originate for the first time in adulthood, like so many other psychiatric conditions like psychosis, depression, and anxiety. Now, autism by definition has to have been present in early life. And therefore, even though it's not necessarily always diagnosed in early life, increasingly we are identifying people with autism at an earlier age, and early intervention becomes relevant, but also adapting a person's education, identifying the best form of school placement, whether it be in a mainstream school or a special school, is absolutely critical to ensure that the person with autism is given the best opportunity to learn and develop it and to maximise their functioning. So let's look at what characteristics or criteria are required to make a diagnosis of autism. So there are really two main criteria here. So the first I've identified here are persistent deficits in social communication and social interaction. And this includes things such as social emotional reciprocity, or the ability to engage in typical social interactions with their peers, with their families, with others in the community. Non-verbal communicative behaviours, so this can include gestures, eye contact, and similar behaviours. And really deficits in developing, maintaining, and understanding relationships. So we often think about the inability to be empathic or to understand how other people feel. And this, of course, leads to significant difficulties in forming and maintaining social relationships. The next major area of autism is around these restricted, repetitive patterns of behaviour, as well as interests and activities. So we often see stereotyped motor movements. So this is often easily observed and quite often makes the person with autism stand out to the casual observer. these inflexible adherence to routines, and this is often where the overlap or superficial overlap with OCD, the person who must do things in the same way over and over again, or if their usual routine is disrupted, they become highly anxious, frustrated, and even aggressive in order to ensure that their routine is maintained or reinstated. Often they have, people with autism have very restricted, fixated interests that are abnormal in their intensity or focus. Of course, whilst all of us can have particular interests that we enjoy, it's usually not to the exclusion of all other interests or all other activities that we would normally participate in. But a person with autism can, in fact, have interests that dominate their world in a way that all else becomes secondary to that interest. And the last one there is around sensory inputs, which can often be quite either heightened or diminished. So they can be exquisitely sensitive to things like sounds, touch. You know, the casual touch of another person can be experienced as being highly aversive, or they can be hyposensitive. So sometimes they can be very tolerant of high amounts of pain, which can be a problem if they're experiencing a health condition where pain is a part of it, but they don't experience pain. So this can be a major problem with people with autism. Next slide, please. So people with autism don't necessarily have intellectual disability, but a significant proportion do have a degree of intellectual disability, anywhere between mild to very severe. It is on a spectrum, and it can be considered a variant of emotional and sensory processing as distinct from what we might call neurotypical. So we often hear the term neurodiversity, and people with autism will often refer to themselves as being part of the neurodiverse community. And we now think about autism as not being a medical condition or illness per se, but it can be associated with a range of other conditions, such as anxiety. People with mild to severe intellectual disability are more likely to have more significant autism spectrum disorder, say level 2 or 3. It's now characterised as having level 1, 2 or 3, as opposed to previous diagnostic classifications, which referred to things like Asperger's disorder, which is no longer part of the agreed nomenclature. We now call that ASD level 1. But if you have an intellectual disability, you're more likely to have a more severe form of autism. And the comorbidities, particularly anxiety, emotional dysregulation, ritualistic behaviours, and impulsive aggression, are also more likely to be severe in those people who have both intellectual disability and autism. Next slide, please. So challenging behaviours is a term, somewhat euphemistic term really, but it's a term commonly used to describe behaviours that are of an intensity, frequency or duration where the physical safety of the person with the behaviour or other people is placed in serious jeopardy, or where that behaviour is likely to seriously limit or delay access to and use of ordinary community facilities. So these behaviours can include interpersonal aggression, so aggression between that person and others, and this can include either direct aggression or property damage, where they might threaten people by throwing things or smashing doors, things like that. It can include self-injury, such as biting, scratching, punching or banging their heads, or socially inappropriate behaviours, such as touching other persons, exposing their genitals and things like that, so sexualised behaviours. Next slide, please. So this moves us on to adolescence. So what I've talked about before is kind of a prelude to the issues that occur in adolescence. And the most challenging age group, in my experience, dealing with intellectual disability is indeed adolescence, and particularly that adolescence and youth period, starting from 12, but probably more so post-puberty, right up until about the age of 30. And it's particularly those people with comorbid, moderate to severe intellectual disability with autism, level 2 or 3, that pose the greatest challenges. And there is a preponderance of males in this clinical cohort. I would say the ratio would be about 3 to 1 of males within that cohort that pose the greatest challenges. And the mental health issues generally relate to things like severe anxiety, both self-injurious and the socially inappropriate behaviour, such as sexualised behaviours and aggression, which we might call challenging behaviour. Next slide, please. So what's going on? Well, developmental factors clearly are relevant, and it's the perfect storm of both normal development. So obviously all young people will go through puberty around this time, and it collides with pre-existing disabilities. So puberty and associated physical and sexual development is occurring around the time of their usual disabilities that are also creating the need for separation and individuation from families and carers. And it's, of course, a period of significant transition. So they'll often be moving from school, and it's often a special school or at least a support class in a mainstream school, into their post-school placement, which is often uncertain. It's often not clear at that time what they'll be moving to. Will they be moving to a community participation program or a supported employment through school leaver employment service? So it's often unclear, and it's often uncertain, not only for the young person, but for their family. They'll often be moving from a family home to supported independent living, and sometimes that will happen at quite an early age. So that might happen either during or soon after school. And as I think Jackie will be talking about, they'll often be changing from paediatric to adult health services, and that can also be quite a challenging transition, both for the young person and for the family, in terms of navigating that change, which often occurs around the age of 16 to 18. And of course, if you have autism, you get heightened anxiety in the face of any change to that highly structured familiar routine. So change can be quite problematic. And we've seen that recently, particularly in the COVID pandemic, where there's been lots of change for people, where they've been disrupted around attending their school or attending their day programs or attending respite care, which has been disrupted. Next slide, please. So clinically, young people will often present an acute crisis, which often occurs after a series of smaller crises or chronic tension and conflict, which we might call the last straw. And it can sometimes develop into a pattern of recurrent presentations with similar features and triggers in a health system that is under significant strain and simply unable to cope, which we might call the revolving door, so presenting frequently to emergency services. Carers, both personal and professional carers, often experience burnout, and they are looking for simple solutions to inherently complex long-term problems, and often those simple solutions involve medication. The acute hospital can become a place of refuge, or if it's an emergency service such as police and ambulance, a place of safety. So the hospital becomes a place of safety that police and ambulance can take a young person to, drop them off, and hopefully leave them there for a period of time. Next slide, please. So what are the challenges with assessment in a young person? Well, clearly there's significant communication deficits as the person may be non-verbal. And when they are verbal, they often can't provide an intelligible history or a sequence of events as to what's been going on. However, even in such a patient, the therapeutic engagement remains a critical aspect of assessment and management. So you still have to find a way to connect with such a person, to make them feel at ease, to make them feel as though you're on their side and that you're trying to help them. Clearly, they're often going to be hyper-aroused and hyperactive, and they may require, unfortunately, for safety of everyone concerned, they may require a degree of environmental or physical restraint or use of PRN medication at times. Next slide, please. So the carers, challenges with carers. You've got professional carers often, if we're talking about group home staff, and they will have variable levels of familiarity and useful knowledge about the patient. For example, in my experience, they often don't bring adequate information, particularly if it's an emergency and they haven't been prepared. So they won't always bring medication charts, Webster packs, recent incident reports or sleep charts, and really useful information that you need to work out what's been going on. So you may not have that information to hand when you're doing your assessment. And that can include whether it's at hospital or indeed if they're coming to a GP appointment in an emergency. Family carers, such as parents, will often bring variable levels of wariness or skepticism to any encounter with the health system, whether it's, again, with a specialist or a GP, which is based on their past, often extensive experience of ignorant and unempathic health professionals. Again, and being a parent myself of somebody with a disability, I know that it can, you do get a variable experience of health professionals, and that can make you a little bit skeptical of what you're going to receive next time you turn up, particularly in an emergency when you're already feeling highly stressed. Next slide, please. So what are the principles of assessment? Well, you need to consider the person in their totality. And I guess one phrase we might use is don't be blinded by the ID. That's the first thing often most health professionals will see is a person with an intellectual disability, and that sort of overshadows everything else. And it's important not to allow that to completely blind you to what else might be going on. So you need to be as thorough in your assessment as you would be for any person with normal cognitive functioning. And this is an axiom that is useful in all of medicine, and which I'm sure we're all familiar with. We miss more by not looking than not knowing. We have the knowledge, but we often don't look. And in this case, we don't look because we are blinded by what we think is in front of us, the intellectual disability, and we don't look behind the intellectual disability. So we do have to rely more heavily on collateral sources of information. In other words, personal professional care informants, rather than the patient self-report, which is often not possible to gather or not reliable. And we do have to rely on data analysis, such as incident reports from the group home, or indeed from a parent sometimes. And also, critically, sometimes results from pathology and imaging, which can be very important when the person can't tell you if they're experiencing pain, but you can look at something from an X-ray. Key questions to ask would include, how is the presentation different to the person's usual baseline state? And that's really important. I mean, I'll often, when I see somebody for the first time, say, well, look, you know, the person clearly has a range of difficulties and disabilities, but the way I'm seeing them today, how is this different? I don't know them from previously, but you need to tell me, the carer, the family, you need to tell me, how is this person different today to how they normally present? Because I can't tell. I don't know how they normally present. So somebody else needs to tell you that. And then over what period of time has it change occurred? Has it occurred over a week, a day, 6 months? So that's really important as well to tell you the acuity of the problem. And also, has it occurred before? Is this in a recurrent episodic condition, or is this something new? Next slide, please. The environmental context is clearly likely to significantly influence the assessment. So anxiety, agitation will be considerably heightened in somebody with ID or autism if they're unexpectedly taken to an unfamiliar clinic for assessment. So that might bias the degree of how unwell you perceive them to be, or their level of mental health problems could be biased by the context in which you assess them. And, you know, cross-sectional assessment is always problematic in my view, whether somebody has an intellectual disability or not. So there's likely to be lingering uncertainty, and so any diagnosis you make is bound to be provisional. Don't draw a firm conclusion based on a single cross-sectional assessment if you've never met the person before. Next slide, please. It's really important to draw on the knowledge of other health professionals who are familiar with the patient. So if the person already has a pediatrician, a psychiatrist, a neurologist, a psychologist, you know, access that information. You know, seek out any previous letters and reports. It's so important because that might be critical in you forming your own opinion. You know, if your opinion concurs closely to those, then you can be more confident. If your opinion seems to be quite markedly at odds, then you need to ask more questions. You need to then check yourself and be more skeptical about the opinion you've formed if it seems to be different to other people. Next slide, please. Okay, so look, I just want to change tack at this point, and you may well have some questions which we can go through at the end, but I just want to talk a bit about carers and families. And as I've kind of alluded to, I fall into this camp myself as a carer, but I think it's so important to actually look at these issues, and it's particularly around young people. So I just want to go through a few slides, and hopefully this will get you to reflect and think about this, because when you see young people with intellectual disability, you'll invariably see their carers. And I just want to really highlight some issues here for you to think about in the broader context. So carers for people with an intellectual disability, young people in particular, have needs that really need to be borne in mind. And you know, the carer role commences abruptly and unexpectedly, often at birth or in infancy when things don't go to plan. So you don't plan to be a carer of somebody with intellectual disability. It just happens to you, and you deal with it. I mean, what else can you do? You have to deal with it. And it's also not uncommon for families to have multiple siblings with degrees of disability. So you know, I often see families where there's more than one child with autism, for example. And of course, that increases the carer burden if you've got multiple children with a disability. Now, parents are going to feel overwhelmed with a vast array of challenges that confront them with the passage of years. The systems that need to be negotiated: health, education, disability, welfare, and more recently, of course, the NDIS has come into play. So it's a huge number of systems. It's really challenging and difficult. Next slide, please. Social exclusion is very common. Families, parents are simply unable to participate in previously enjoyed activities. You lose touch with your friends. You lack meaningful support from extended family who often don't know what to do, so they end up excluding you because they fear becoming over-involved and having to provide excessive support, and so they simply do the easy thing and turn their back on you. Not always, but it can happen. You're unable to enjoy the simplest of pleasures, such as dining out, going to a movie, and so often carers will become increasingly housebound in their carer role, looking after their son or daughter with an intellectual disability. You can become silent victim of domestic violence from an adolescent or adult child with intellectual disability or autism. You frequently become in harm's way of attempts to set limits, or alternatively, you end up just giving in to increasingly unreasonable demands from a child who is demanding things either because of their disability or because of other factors. But then on the flip side, you'll protect your child at almost any cost from being subject to legal sanction. So if the child is violent, the last thing you want to do is call the police and be at risk of that child then being hauled off to a police station or put before a court until matters completely get out of hand and to the point where your life is at risk, and then you have no other option. And I've seen this happen so many times with families. Relationship breakdown is very common. Higher rates of separation and divorce in the general community, much higher rates actually. And then, of course, that makes the custodial parent more vulnerable in a single parent family. Siblings are significantly affected. An older sibling may take on a parentified role as a supplementary carer, often to the detriment of their education and social development. And a younger sibling can become anxious, fearful of an aggressive older sibling, and similar consequences in terms of to the detriment of their development. And of course, the final common pathway that we often see is that the child with a disability is relinquished. A decision made often seemingly in haste, in crisis, with no plan and the need for services, including health, sometimes to step in and pick up the pieces when the child is dropped off at hospital because alternative accommodation options simply haven't been found. And yet, as you've seen from the previous slides, these seeds for this crisis that appears to have emerged overnight have actually been sown many years earlier. And I would suspect that in primary care, you may well see these families for many, many years before these crises occur. And I wonder sometimes whether there's more that all of us can do, including those of you in primary care. So what happens after that? In the aftermath of relinquishing a child, parents are likely to feel a range of emotions, which can include guilt and shame, believing that they might have abandoned their child, anger, that the system as a whole has let them down, has prevented them from continuing to care for their child at home if that was their wish, as many families wish to do. Sometimes it's a feeling of relief that the pressure has been removed, that an agonising decision has been made. Perhaps that final decision was taken out of their hands, which in some ways makes it easier. And of course, inevitably, grief and loss. And of course, that may reactivate similar emotions of grief and loss, which were experienced at other critical points in their carer journey. I think that's all I wanted to say, really. So I've left a few minutes for questions, if anybody has any questions at this point.
Yes, we do have one question. Jenny, do you want to read the question? I'll read it. Unfamiliar environments and situations can be upsetting to people with ID. What are some best practices in preparing for an initial consultation in a clinic or home setting?
Thank you. It's a very good question. Well, a clinic and home are obviously different settings, aren't they? I think if you're seeing someone in a clinic for the first time, you know, one, obviously making the clinic as welcoming as possible. So having a clinic room, and of course it's going to depend a little bit on the age of and developmental age of the person you're seeing. knowing a little bit about the person in advance, possibly, if you've never seen them before. So maybe in that occasion, you might want to talk to their carer beforehand and find out if there are particular things that the person likes or indeed dislikes. You know, if they particularly dislike loud noises, you know, can you have the clinic space somewhere a bit more quiet, or a room that is less noisy than one of your other clinic rooms? If they particularly like certain furnishings or things for them to be soothed by, to make sure that they can either bring them in or that you've got things in your room. Most clinic rooms aren't going to have sort of play equipment, but you know, to enable them to have enough space that they can bring things in with them if they wish, to enable them to feel comfortable. That's really important. And most things that people bring in with them to be soothed, whether it be an iPad or a soft toy, shouldn't pose too many problems. But just to make sure that people feel comfortable to bring in the things that they feel comfortable with. So I think definitely doing a little bit of homework and research beforehand, if that's possible, to talk to carers and get that information, or even if you can do it via email at a convenient time. If you do a home visit, and obviously that's a good thing to be able to do if it's feasible for you. Again, you want to be able to make sure that you're going to be safe and that the other person is safe. Clearly, you would have carers there to chaperone you and make sure that the environment's appropriate. And you'd see the young person in the place in the home where you could see them. If you had to do a physical examination of some sort, you would make sure that was done in an appropriate place that made everybody that was feasible to do that, and the young person felt safe according to the kind of examination that was required. And look, you know, Jackie might have some other thoughts about this that she might want to talk about as well, because most of my expertise clearly in doing psychiatric evaluation. But you know, I think when the opportunity arises to plan an assessment, it's always going to get better than an emergency. I think emergencies are always going to be fly by the seat of your pants to some extent. But even in those situations, paying some attention to the broader needs of the young person, rather than just sort of diving straight into, okay, what's the problem today? You know, where's the pain? What's your issue? What's your medical issue? But thinking of the broader context around, how do I make you feel comfortable? How do I allow you to kind of settle into the process, rather than just going straight into what's the health problem today? I think that's always going to help, but it will take time. So I think you need to allow a bit more time for a consultation with somebody with an intellectual disability, ideally, to ensure that you get the most out of it and that you make them feel comfortable. Hopefully that answered part of your question.
Thanks, Adrian. Next question, we've got quite a few questions here. Can you speak a little more about differentiating psychosis from ASD or ID?
Okay, I'll try and answer that briefly. That's quite a big topic. Clearly, psychosis and intellectual disability can coexist. So differentiating the two of those is not so much an issue of they're not mutually exclusive. Okay, so intellectual disability and psychosis can coexist. Where you would have more challenges is knowing, for example, if a person talks to themselves or has imaginary friends, which is quite common in intellectual disability, is that a hallucination? So there are times sometimes when I will need to really see a person a couple of times or get a really good collateral history to know whether a person's inner experiences represent, for example, hallucinations, or whether some of their expressed beliefs around fear is anxiety versus actual, you know, paranoid or persecutory beliefs. So sometimes that can be challenging. Again, I'll often look for changes in behaviour, and I'll get that from the collateral information from the carers. Has there been a distinct change? Because psychosis usually represents a clear change at a particular point. It rarely begins in early life. So if somebody's been experiencing imaginary friends from the age of 5 and nothing's changed and they're still like that at the age of 18, that's not normally psychosis. But if they've usually been okay and there's been quite a marked change of behaviour around late puberty, early adulthood, then that's more likely to be psychosis, because it's the time when psychosis usually emerges. In terms of ASD and psychosis, again, people with ASD will often have unusual ritualistic behaviours, high levels of anxiety, but hearing voices, having persecutory beliefs is not typically present in psychosis, but ASD and not typically present in ASD, but ASD and psychosis can definitely go together. So the features of psychosis that are present in people with or without ID, if they're there and they also have ASD, then you can make the diagnosis concurrently. You don't have to, they're not mutually exclusive. So that's probably how I'd address that.
Thank you, Adrian. We have a comment now and then another 2 questions. The comment is, thank you for speaking up as a carer. Everything you mentioned about family situations is so true, especially about being silent victims of domestic violence. The next question is, what treatment or therapy options are there for anxiety?
Okay. Well, treatment for anxiety would be both psychological and pharmacological. Clearly, as a psychiatrist, I'm more commonly myself using pharmacological options, but I refer a lot of patients for psychological therapy. Dealing with pharmacological first, I would generally use the SSRIs as my first-line treatment. But if autism is present, I'll often use medications like risperidone, particularly when the anxiety is associated with impulsivity and agitation and aggression. I find and hyperactivity. I find risperidone to be very effective in those patients, but SSRIs are also very effective, although they don't work with everyone, and you do have to be cautious and usually start at a low dose. So I'll often use fluoxetine as a first-line treatment, starting at about 10 milligrams and cautiously increasing it if there's good effect. But other SSRIs like escitalopram and sertraline can also be effective. With psychological therapy, again, at the milder levels of intellectual disability, that can be quite effective. When you move into more moderate to severe, then you're usually looking at behavioural therapy rather than cognitive behavioural therapy. But behavioural plans, particularly when they're implemented by professional carers or family who can use behavioural reinforcers, can be very effective even with moderate to severe intellectual disability to help. And you usually obviously structured routines helping the person to feel comfortable and safe. That's really important as a psychosocial strategy.
Thanks, Adrian. Last question. Is there a fail-safe service one can call which provides speedy help for a family in crisis? Most numbers are either leave a message or I will call you back.
Oh, that's a very good question. I don't have one on the tip of my tongue. Perhaps others do, or we might have to research that one for you. Fail-safe? Absolutely not. I don't know of any fail-safe service. And to be honest, acute care mental health services that I would recommend for general mental health services, they'll do their best, but they do struggle with this population. They often don't have a lot of experience, and they'll often suggest if there's a crisis, you need to take the person to emergency, and that often is what happens, particularly if the crisis has reached the point where the person's becoming aggressive to a carer or is self-harming significantly. So it is difficult. We really do try and step in and recommend prevention rather than cure, trying to intervene at a point where strategies can be implemented before it reaches a crisis. Because I think once the crisis has occurred, there's little to do other than call an emergency health service or emergency services, and at the moment that's probably the best go-to that we can do.
Thank you, Adrian. There are no more questions. Thank you for your time tonight. Our next speaker will be Philippa Cook, Psychosocial Aspects of Identity in Intimacy and Family Relationships, including Siblings. Over to you, Philippa.
Good evening, everyone. On this first slide, we can see some of the important psychosocial aspects of a person's identity. We don't need to have all of the pieces of the pie, but all of them can contribute to and enrich our positive sense of ourselves. In this talk, I'll explore the strengths and challenges of young people with ID as they transition into adulthood and create their adult identity. I will also look at the ways in which health practitioners can help foster and support this transition. I'll begin with one of the most important ways, the way we communicate. The way we communicate with any human being can either hinder or help these aspects of a person's identity. With our communication, we not only can facilitate the sharing of helpful information and advice, for example, about the housing options or employment options and so on, but we also can convey respect for and interest in the person in front of us, which is an important part of building a meaningful relationship and adding to a person's sense of belonging and community. Next slide, please. I would like to share these communication tips written by people with intellectual disability who work for the Council for Intellectual Disability, CID. You can find more detail on these tips on the CID website. Next slide, please. And the next slide. I will now read a case study from the Australian Family Physician. The article was called Overcoming Communication Barriers, Working with People with Intellectual Disabilities. And this case study demonstrates the excellent use of many of these communication strategies outlined by CID. So John, 28 years of age, has come to see his GP for a health assessment, accompanied by his mother, Anne. John has autism, a moderate intellectual disability, and communicates with speech. During the consultation, the GP speaks to John to involve him more actively in the consultation. John, however, responds with only single words and simple phrases and doesn't seem interested. His GP decides to speak with John's mother about his overall health and asks John for permission to do so. John does not answer, but looks at his magazine while the doctor speaks to his mother. The GP asks about John's health since the last consultation and hears that John has been well, apart from having frequent back and/or neck aches, possibly related to postural problems. The GP then shifts the focus back to John, demonstrating to him several exercises to help with his back pain. During this part of the consultation, John gives his GP his full attention, mimicking the GP's actions, but goes back to looking through his magazine immediately after. Next slide, please. I'm now going to explore in more depth some of the psychosocial domains we looked at earlier that help support the development of a young person's identity and positive sense of self. Safety is obviously a crucial element in enabling an adolescent's positive sense of self to develop. Some of the key areas in which health professionals can support a young person's safety is to support their safety around the relationships in their life. Adolescence is a time when a young person's peer group becomes very important to them, and it is also a time when young people start to have sexual relationships. It is important to explore this area in young people's lives because of the risks of sexual abuse and domestic violence. I'll read out a section of an article from the Australian Family Physician titled Intellectual Disability, Sexuality and Sexual Abuse Prevention. People with intellectual disability are prone to physical, psychological and sexual abuse. These problems may present to GPs as mental illness and/or challenging behaviours. Perpetrators may include family members, support workers, intimate partners and co-residents. People with intellectual disability may lack the assertiveness to report abuse or the verbal skills to describe it. When abuse is reported, responses may be inadequate. Lack of sexual knowledge, relationship experience, and protection skills may increase the risk of abuse and impair the ability to recognise an experience as abusive. There are some excellent resources available from Family Planning New South Wales to help teach people with intellectual disability about safe sex and safe relationships. Next slide, please. So Family Planning New South Wales resources include All About Sex, which you can see on this slide. It's a series of fact sheets for people with ID and the people who support them. The fact sheets are easy to read and include illustrations to help people with ID learn about sexuality and relationships. They cover a range of topics, including bodies, relationships, sex, pregnancy and reproduction, sexual health, and sexual assault. Some people with ID will be able to read these sheets independently, while others will need the support of a family member, teacher, support worker, or advocate. The fact sheets have been designed to make it easier for support people to have conversations and provide information about sexuality and relationships. Next slide, please. This is another resource from Family Planning New South Wales. This is a resource pack called Sex, Safe and Fun, which you can download for free on their website. This resource presents a factual and balanced view of the rights and responsibilities associated with a range of sexual activities. There are important messages about consent, enjoyment, intimacy, privacy, and safety. Throughout Sex, Safe and Fun, key messages about sexual behaviours and activities are termed good sex or bad sex. Good sex is used to describe behaviours that are consensual, private, enjoyable, safe, and within the law. These are presented in contrast with bad sex. Bad sex is used to describe behaviours that are unsafe, generally not socially tolerated, and in some cases illegal. Next slide, please. Another great resource is an app made by 1-800-RESPECT for women with intellectual disability who are experiencing or at risk of experiencing domestic violence. According to the Association of Children's Welfare Agencies, statistics show that women with disability are approximately 37.3% more at risk of domestic violence than their peers. In New South Wales, 43% of the women who experienced personal violence in 2011 were estimated to have a disability or a long-term health condition. This is 7% higher than the national average. The app is called Sunny, and as you can see in the first photo, it can be disguised on a person's phone as a weather app. It uses simple words and images and helps women write their story using an easy keyboard. The app helps women to recognise, respond and get help if they're experiencing violence and abuse. Next slide, please. As well as forming new relationships and becoming closer with peers, the immediate family is still, of course, a very important part of a young person's identity. The health and well-being of carers and siblings is inseparable from the health and well-being of the young person with intellectual disability. If one or more members of a family are struggling, it impacts upon the entire family. In this and the next couple of slides, you can see some of the resources available to support siblings and carers. As we heard Dr. Keller speak about, carers can often experience burnout and overwhelm, and siblings can experience real difficulties as well. Next slide, please. The following is a paragraph from the SIDHT Facebook support group for teens run by Siblings Australia. It says, the teen years present a number of challenges to young people. Sometimes things can seem even more difficult when your brother or sister has a disability or illness. Whilst you might love and care deeply about your brother or sister, you might also have some of the following feelings: sadness, resentment, anger or embarrassment, guilt about your own abilities and successes, fears about the future and who will care for your brother or sister, concerns about creating your own family. And in my role as social worker on the New Strides team, I've already worked with siblings with depression, anxiety and suicidal ideation. There is clearly a real need for siblings to be referred to support groups and organisations where they will no longer feel alone in their experience and find the support they need to develop their own positive identity and sense of self. And the next slide. And the next slide. I'll now talk about safe housing, another important part of any person's identity and well-being. Moving out of the family home is one of the powerful ways that young people individuate from their parents and create their identity as an independent adult. Moving out of home, however, is often more challenging for people with an intellectual disability. The NDIS provides funding for supported independent living options that can provide the support necessary for young people with an intellectual disability to achieve this independence and the self-esteem and confidence that can come with it. It is worth discussing these housing options with young people and their carers, as they may be unaware that this type of housing is available. In my work with Strides, I worked with carers who thought that the only alternative options to living at home were hospitals or institutions. It can be a real relief for both young people and their carers to know that there are many different types of supported independent living. As a GP, you might be able to give them the reassurance and the confidence that there are safe and good quality housing options other than the family home. I spoke recently with a carer about her past experiences caring for a family member with a disability. She's from an Indian background, and she spoke about how in her culture, families are expected to provide all the care and support to a loved one without accessing external supports. She said it was challenging for her to navigate cultural and family expectations around the use of out-of-home respite or day programs. She recommended that it might be helpful for GPs to explore potential cultural barriers and to normalise access to supports outside of the family. For example, saying to the family, in Australia, you have access to supports that didn't exist in India, and it's okay for you to use these services and supports. This carer felt that hearing this kind of encouragement from health practitioners enabled her to access these supports in spite of family resistance. Next slide, please. I'll move on now to have a closer look at some of the other important psychosocial parts of identity. Developing meaningful relationships, belonging to a community, and being able to pursue hobbies and interests can have an enormously positive effect on a young person's ability to transition into adulthood with a positive sense of themselves. For young people with ID, this can be challenging. However, supporting their opportunities to make friends and socialise is very important. One of the biggest challenges to this is stigma. And this includes not only the negative attitudes and beliefs from the wider community, but also the negative self-beliefs within people about their ID. This has also been called internalised ableism. Fortunately, there are many organisations and programs that are addressing this issue. One such program is the peer support program run by the New South Wales Council for Intellectual Disability. There is a video on the CID website about this program. And I will quote George and Lee, who speak about their own experience with peer support. George says, there's this perception that people with disabilities don't know what to say or don't know what to ask. And families get stuck in that because they see their own lives and their own challenges with their own children. And these children are in their 20s, some of them in their 30s, and they're not children, they're adults. And for them to be able to come out free of their parents into a peer group, it gives them the opportunity to learn to become independent, learn to make a decision. Lee says, they start to bloom, they start to grow, they start to realise they have abilities, they have power to take control of their life and start living it the way they choose. Another program worth mentioning is called Dance for Abilities. Dance for Abilities is a free social dance night exclusively for people with ID. And they can feel every bit included, and they're also included in designing and running it. DFA creates social events that mirror the types of functions and settings we all enjoy and take for granted in our lives. There's also an organisation called Gig Buddies Sydney. This organisation pairs adults with learning disability with volunteers to go to events together, such as concerts and sporting events. Next slide, please. Another community that contributes enormously to reducing stigma and helping people with ID build a positive identity is the Special Olympics. The Special Olympics is a global sporting community for people with ID. Locally, we have an Inner West Special Olympics Club that provides regular sports training and competitions for people with ID. I'd like to finish this presentation by playing a short video from the Special Olympics. In it, you will be able to hear directly from young people with an ID speaking for themselves. You will hear young people speaking about the importance of good communication from their health providers, how this supports not only their physical health, but also their positive sense of themselves and their ability to belong and participate.
Questions for Philippa? That was a fantastic presentation. Thank you, Philippa.
Thank you.
Looks like we've just had one come in. Can you speak some more about the needs of siblings and how to help?
Aside from the resources mentioned in the presentation, Another thing that I recommend is getting permission from the parents to speak to the school counsellor and trying to link them in for sessions with that school counsellor. We also recommend, of course, other services for youth in general. I'll just click this. There we go. So the Kids Helpline, Headspace, and I think that's also Croydon Health Centre. If they're in that local area, they also run school holiday camps for siblings. And that can be a really great way for them to meet other people in the same situation and get that sort of peer support.
Thank you, Philippa. Thank you for a great presentation. Now we're over to Dr. Jacqueline Small, the role of the GP in providing support with menstruation, sexuality, transition from child to adult services.
Jenny, thank you. Jenny, I can't see anything other than a blank screen at the moment. Can you see my video?
Yes, I can see your video.
And my webcam and the slides, so I can't see the slides either at the moment.
So, Maren, can you see the PowerPoint?
Yes, I can see it.
Okay.
I can see Jackie and the PowerPoint.
Okay,
so
well, I might just proceed with the understanding that's a little bit difficult to see anything at the moment. I want to thank Adrian and Philippa for two amazing presentations. I think, as Adrian has highlighted, challenging behaviour and mental health issues through adolescence can be really challenging and take families to a crisis. I couldn't agree more with his encouragement to look at some of those earlier determinants, those factors that might start emerging earlier on, so that we can potentially intervene and prevent a crisis from development. And I'd just like to add to actually have a team around the child and the family established as early as possible is crucial, with the GP providing that continuity. I was really appreciated Philippa's reframing and detailed reframing of the adolescence period. It's given me a lot to think about, and I think probably you as well. But really, I think the take-home messages were just uttered in the video we saw just now. When you were asked to treat someone with a disability, you say yes. So hopefully that will be our motto and key message moving forward. So I'm going to be speaking about providing health care for adolescents with intellectual disability and touch on some key issues. Thanks, Jenny. Next slide. So I'll start out by talking about consent. I'll refer to a slightly aged but still relevant consensus statement produced by the College of Obstetrics and Gynecology, address some of the issues in clinical assessment and management of menstruation for young women with intellectual disability, considering some of the cultural aspects that both Adrian and Philippa have already touched on. That is a factor for many people in a range of areas. I'll just refer to a few issues about sexuality to pick up some of the things that Philippa has already mentioned, and finish off by highlighting some of the important approaches for transition, that critical period, particularly the transition from childhood paediatric care to adult care, and how we might approach that. Thanks, Jenny. So just speaking a little bit more about consent and the legislation that guides us in consent, which is particularly important when we're starting to address issues of sexuality and reproductive health. Thanks, Jenny. Next slide. So it is unlawful to sterilise a person with intellectual disability without valid consent. Since 1992, it's been unlawful to conduct a procedure that results in the sterilisation of a person who's unable to give informed consent without the legal authorisation of the Family Court of Australia for a woman under 18, or the Office of the Public Advocate and the guardianship if the woman's 18 or over. So in other words, the family is not allowed to consent to sterilisation for a young woman with intellectual disability. While this may seem restricted to parents who are wanting to pursue it, it is designed to keep the best interests of the young woman or the person with intellectual disability first and foremost, respecting their human rights. Next one, thanks, Jenny. So just in general, some of the principles around consent for medical and dental treatment rests on the patient themselves being the one who we ought to expect to provide consent to treatment wherever possible. That's the first and most important principle. As we know, many people with intellectual disability are not able to understand some of the complexities of medical procedures and may require support to understand and provide informed consent. For some people, there may be a substitute decision maker or provider of consent. This responsibility can be delivered by a variety of people, and it may be a close family member or a friend known as a person responsible that's defined by the Guardianship Act from 1987. If necessary, the Guardianship Division of the New South Wales Civil and Administrative Tribunal can get involved and provide advice and recommendations. This may be the case if there is no suitable person available, or if there's dissent between close relatives, or a concern that the person who has been appointed as a person responsible is not taking the best interest of the person with intellectual disability in mind. The guardian may be appointed by the NCAT, or alternatively, there may be an enduring guardian. And on your slides, you'll find a link to this resource. There are some special conditions, however, where, as we've already heard, formal and legal consent must be sought. So there is a description of criteria of special medical treatment. In young women less than 16 years of age, this includes sterilisation, vasectomy, or tubal occlusion, or any medical treatment for contraception for children under the Care and Protection Act. So in other words, if sterilisation or vasectomy is considered, the NCAT must be involved. Likewise, for people over 16 years of age, through the Guardianship Act, they have the capacity to provide consent for special treatments for people who lack capacity to consent themselves. So this is the next slide, Jenny. One type of special treatment are treatments which are intended to make somebody permanently infertile or is reasonably likely to make a person permanently infertile, such as a hysterectomy. So in other words, if somebody is over 16 and requires hysterectomy, then that needs to be approved by the New South Wales Civil and Administrative Tribunal. Next slide, thanks, Jenny. As Philippa and Adrian have already identified, it is important to consider the normal expectations for people with intellectual disabilities and as part of their experiences. So you are probably more familiar as GPs with normal menstruation than I am as a paediatrician who sees young people with developmental disabilities. But just as a reminder, the median age of menarche is 12 years, and the menstrual cycle typically lasts between 3 and 4.5 weeks or 5 weeks, with a menstrual flow of 7 days or less. Next slide, thank you. So the consensus statement from the Royal Australasian College of Obstetrics and Gynecology from 2003, which I said is a fairly old statement, but I think still holds true. This is about menstrual and contraceptive management in women with an intellectual disability. They state that most girls with intellectual disability have normal menarche and menstruation. Despite the fears and anxiety of many of their parents, it proceeds normally. They do state that women with intellectual disability have the same right to the full range of management options tailored to their specific needs, whether that's education, medication, or any other option. And they also have the right to experience normal menstruation as well. They reinforce that treatment options recommended should always be the least restrictive. In other words, most like other girls their age would be utilising, and always in the woman's best interest. The management of menstrual problems in young girls or minors rarely requires destructive surgery such as hysterectomy or endometrial ablation. Next slide, Jenny. So I'd like to go over the clinical assessment and the initial assessment for young women where there are concerns about menarche and their periods. Much of this will be very familiar to you, but I will draw out some of the issues that are more specific and relevant for young women with intellectual disability. Whenever you're assessing a new patient with intellectual disability or somebody you may not have seen for a long time, it is always important to start with understanding their current skills, their adaptive skills, especially those related to self-care, general support needs for negotiating daily life, and their ability to understand and communicate with other people. It is important to think about how they localise and indicate pain. Some young women are not able to indicate pain other than distress or perhaps crying, whereas some women may be able to specifically identify where they experience pain. Some people may just make some general statements of pain and not be able to localise it. It's important to know what is relevant for that young person. Understanding their general cognitive skills will assist you with understanding issues around consent and the general ability to understand information which you may be giving to them or other procedures or medication you may be prescribing. You might want to think about their own ability to manage the physical demands of menstrual care, such as changing pads and maintaining hygiene, with a general advice being that if a young woman can manage her bowels and keep herself clean, then she's able to manage menstrual needs. However, those with more severe intellectual disability are likely to need support with managing their toileting and menstrual care needs. And so time and preparation should be put in advance of when menstruation is likely to occur for these young women involving other members of their family. It is likely that some women will need considerable assistance from other people in their lives, such as their daycare facilities if they go to any respite care, and particularly their school staff. It is important, most special schools are very experienced with helping to manage a young woman's menstrual needs and consider this part of their responsibilities. When looking at the needs of parents and carers, it is important to start discussing who might be involved with providing the care around the menstruation. This is likely to be the women in the family, but there may be male members also involved. There may be siblings involved and other staff who support the person when they are away from home, out in the community, for example. It's important to identify all of these people and involve them in the preparation for menstruation and the menarche. Next slide. Your initial assessment will also include the menstrual history, the onset of menarche, and details about the menstrual cycle. This doesn't differ from any other young woman. Some issues of the general health, however, are specifically relevant for young women with intellectual disability. If the cause of the intellectual disability has been identified, there may be some specific relevance to puberty, menstruation, and other issues that may be relevant to consider. For example, although it isn't common, Fragile X syndrome is associated with early puberty, and Prader-Willi syndrome is also associated with some delayed menarche. A history of headaches and migraine may be important to take account, particularly if you're considering some medication, and this may be hard to identify and may be only effectively identified by keeping data and having good conversations, as Adrian said, with other informants who know the person well. A history of epilepsy is important to identify because there may be an increased number of seizures through the period of adolescence and in association with menstruation. It's important to look for factors associated with osteoporosis if you are considering medication in particular, and particularly young women who may be relatively immobile may be at increased risk for osteoporosis, or those who may spend quite a lot of time indoors, not able to get outside without supervision of their parents, may be at risk of low vitamin D. Many young people with intellectual disability have lower physical exercise on a day-to-day basis than their typical peers, and this may also contribute to their health risks. It's important also to look at the risks of thromboembolism and consider the risks of pregnancy and sexually transmitted diseases. And I'll speak a little bit more about this shortly. Next slide. Your initial assessment might involve keeping a diary for menstruation and include other factors such as pain or behaviour. It may be that changes in behaviour are the sign that a young person may be experiencing some pain, and documenting this in a behaviour diary may be helpful and point to some specific interventions that may be appropriate. As Adrian has indicated, your physical examination usually requires or involves the support of a carer or another support person, and that person should be chosen carefully as somebody who has the confidence and trust of your patient themselves. It is important to adequately explain any physical examination you're doing, and for young people, this might also, with disability, it might also involve using visuals or social stories and simple language to explain what's happening. While there's not specific reproductive or sexual health visuals available on the Say Less Show More site on the Agency for Clinical Innovation Intellectual Disability Network, there are some general physical examination and other visuals that may be helpful for you in practice. You may consider a gynecological examination if there's specific suspicions of cervical pathology or other genitourinary pathology. I won't go through the other investigations, as I would suspect you're probably more expert than I am, but do consider specific conditions for which abnormalities of, say, thyroid function may be more common, as you would see in somebody with Down syndrome. The etiology can help identify associated physical and mental health conditions. Next slide. Some of the key issues in managing menstruation. As I've mentioned, the general guidance is if the young woman can manage toileting, then she can usually also manage her menstrual needs, even if some of those need to be explicitly taught and we need to give her more time to learn those tasks. Education remains the first and foremost aspect of intervention to support menstruation in young women. This may require some additional resources, such as those that Philippa has spoken about from the Family Planning Association. They have some excellent resources that can not only explain sexuality, but can explain puberty and some of the other experiences, such as menstruation. They have easy read formats and large pictures that are much more easily understood, and also have some additional resources such as dolls that can help explain pubertal and other changes. Education of the parents is also important. This involves discussing about normalising the experiences of the young woman and helping them build confidence in other people who may also be taking care of their daughter, and helping her with generally fairly intimate activities such as menstruation. Normalising the young woman's experience is important with talking with parents, but also allowing them to disclose with you and discuss any pre-existing concerns they might have, or concerns about their diagnosis, their experiences of diagnosis. It is perhaps the time when young women are growing up and perhaps may bring home to the parents their varied experiences that they have had through the life of the young child, especially reflecting back on the period of diagnosis. And above all, prioritising the rights of the young woman themselves. Next slide, thank you. Management of menstruation is multifactorial, as it would be for any young woman. You might want to recommend some lifestyle measures that reflect on the diet, keeping healthy with exercise and not smoking. Treating dysmenorrhea is primarily based on simple analgesics or other local physical treatments such as heat, but at times you may wish to consider hormonal treatment. As I mentioned earlier, the least restrictive or least permanent option is the preferred, and certainly caution with any permanent treatment. I won't discuss medical management or medication further at this point. Thanks, Jenny. Next slide. So there was a summary of clinic attendance over a 10-year period from Melbourne of 170 young women with intellectual disability who attended gynecological clinics in Melbourne. Their presenting concerns ranged from dysmenorrhea or behaviour changes suggesting pain, for which they were treated with the typical ordinary analgesics of non-steroidal anti-inflammatories. Contraception was provided for sexually active women or those women who are at risk of being sexually active. And in some cases, hormonal replacement therapy was provided to reduce the risk of osteoporosis. Generally, menorrhagia was treated effectively with ordinary analgesics and sometimes hormonal treatment such as the oral contraceptive pill. And they did note that seizures could be exacerbated with the menstrual cycle, as I've mentioned before. They found that even at their specialist clinic, only 2 of the 107 women required surgical intervention, and this included endometrial ablation and hysterectomy after other treatments had failed. So, as I did suggest earlier, the least restrictive practices is the best way forward. It is also important to start to prepare young women for their menarche well in advance of that actually commencing. Next slide, Jenny. Caution. Words of caution, however, relate to a number of issues that are not best managed by menstrual suppression. Many parents may be concerned about the fear of exploitation and sexual assault. And as Philippa mentioned, sexual abuse is more common in women with intellectual disability than the general population. However, there are strategies that can be implemented to support the young person developing the skills to help keep themselves safe, and the parents are able to implement other strategies as are appropriate. Young women who are always supported by an adult, such as those with a moderate or severe intellectual disability, are in ordinary circumstances not likely to become pregnant. The risk of infectious diseases, again, for many young women is also low. 2 slides, thanks, Jenny. Caring for women. This was another study that was done looking at some in a Chinese group that also explored some of the general strategies that women used, mothers used in particular, to support their daughters during menstruation. And I think these have got some lessons for us all. Firstly, it is important that we start preparing young women for menarche, and this might involve their mothers or sisters showing them what it's like when they have their own menstrual periods and are changing their pads. We often do this when children are very young and learning to use the toilet for the very first time. It may also be helpful for young women to become accustomed to wearing a pad even 1 or 2 years before they start menstruation. The more they become accustomed to it, the more readily they'll be able to tolerate it when it's their turn for menstruation. So mothers can try a variety of products in order to support their daughter. They may include pads or nappies or other absorbent material in order to assist with menstruation. They acknowledge that often menstruation involves lots of washing and added costs for sanitary items and nappies. And for people with intellectual disability who are often socioeconomically disadvantaged, we may need to consider this specifically. As I've mentioned, young women may often have difficulty communicating pain, and keeping a behaviour diary may help decipher the reasons for the challenging behaviour as being clearly related to the menstrual cycle. Many of the women who spoke to these researchers felt that it was just another aspect of their care role, and they assume this role with support as they did the other roles in caring for their child. Although often it was actually very difficult to talk about their experience in supporting their daughters. And it is worth us as doctors working and supporting young people with intellectual disability that we raise these issues and give the parents permission to discuss what concerns they may have. Many people, however, have advice for parents, particularly in this situation, about what to do and how to support their daughters. There are cultural beliefs around menstruation for young women with intellectual disability and for all young women. So in this group, it was suggested that menstruation was generally thought to be good for general health. Next slide, thanks, Jenny. These researchers showed that in Chinese societies, menstrual issues are rarely discussed openly and outside the family. So the discussion of these issues with other professionals, such as school professionals, may be quite challenging for people from a Chinese context, and it's worth identifying if that may be a concern. They did suggest that although the body undergoing menstruation is considered to be polluted and unclean, menstruation itself is viewed as a natural process and associated with fertility. And that in itself is a welcome symbol of femininity. So people may have various beliefs in relation to menstruation, and it might be worth asking, specifically asking about their cultural belief in order to understand the various factors that may be influencing the parents' decisions around their daughter's care. Next page, thanks, Jenny. I just want to reiterate some of the comments that Philippa has already made around intellectual disability and sexuality, that many young people with intellectual disability will be interested in having normal relationships with normal romantic relationships that may develop into sexual relationships and even long-term relationships. And they deserve the same experience as other people in the community. They may require some added support and some special education in order to understand the nature of those relationships. And there are many sources for that information. As Philippa has indicated, the Family Planning Association, which is based in Ashfield in New South Wales, very close to many of us, I suspect, has got a very helpful range of information. As you can see on this slide, the Better Health channel also has some very helpful information, and I can commend that website to you. Next slide, Jenny. Some other resources are helpful, and I'd like to draw these to your attention. One that I and others from Sydney Local Health District were involved with developing, Being a Healthy Woman, is available on the New South Wales Health website. And that's designed for women with intellectual disability and explains in simple language with pictures a range of issues they might experience as a woman, including menstruation. The Centre for Developmental Disability Health in Victoria has got a range of very helpful information designed for general practitioners, and there may be something there that might be helpful for you in your management of young women with intellectual disability through their sexual health or their menstrual health needs. And again, the Family Planning Association is an important resource. Next slide, Jenny. So just to conclude, I would like to speak about transition and emphasise that it's important it's a planned process. As Adrian suggested earlier in relation to mental health, planning ahead and prevention is the best approach, and so it is for transition. While the primary healthcare and especially general practitioners ought to be maintaining an important place in the medical care for a person throughout their life, and particularly through transition, for many other parts of the service system, including the education and the health system, there is a dramatic change when a person moves from the children's services to adult services. Transition ought to be a process of healthcare moving in a planned way. Preparation for transition involves equipping everyone with the right skills, knowledge and resource to manage that process, keeping the young person front and centre in all of the decisions that are being made. All decisions should centre on the young person what's in their best interest and their right to live a full life, while also expecting the role of the parents as carers and other people in their life. And I found the framework that Philippa has just presented on identity to be a fascinating and grounding framework to approach the range of needs of young people through this time. I'd like to commend to you the ACI, the Agency for Clinical Innovation Transition Network, resources and website. There's a lot there that I think would be very helpful. And they state that transition is ideally a gradual process that starts early to give you time to plan and prepare. Discussing transition with your healthcare team can start anywhere from the age of 14. So when you're seeing a patient any age from 12 and particularly from 14, it's worthwhile starting to ask, has the family started to prepare for transition? What ought to be done along the way? Next slide. We do recognise that healthcare in an adult hospital is very different to that experienced in the paediatric healthcare setting. It is important, though, that the family remains important and supported by the staff in the adult hospital if the young person is admitted to hospital. There may be carer representatives or other people such as parents, patient friends, or in the case of the Sydney Local Health District and South Eastern Sydney Local Health Districts, specialised intellectual disability health teams who can support young people with intellectual disability who may be hospitalised in some of the adult hospitals. Underpinning all of this is the right of young people to appropriate healthcare. There are a range of resources that can improve their experience in hospitalisation and transition, but first and foremost, we must start by approaching it well in advance of the point of transition and start preparing. Next slide, Jenny. Some of the key things that can start to be undertaken through this period of preparation for transition are on this slide, or the to-do list. Collating important health information in order to provide it to a set of new professionals or services who may become involved is very important. That can sometimes be a daunting task in itself, but it is very important not to lose important information. The young person themselves may warrant obtaining a healthcare card or a Medicare card themselves, but they may need support in doing this. This is particularly the case if they are living away from home or supported by other people. They may be eligible for the disability pension, particularly if they're turning 16, and that may require support in their application process as they require medical evidence. Equipment that may have been loaned from the Children's Hospital may need to be sourced from another site, and this may require support from the general practitioner. It may be worth starting to think about who may be providing consent and ensuring that the young person themselves is maximally involved in this process if possible. Knowing that typically from the age of 14, for most typically developing young people, they would start to assume more role in making their own consent or giving their own consent. So we need to consider that from the purposes of the perspective of the person with intellectual disability and ensure they also remain involved or become increasingly involved as they grow up. Many special schools and other organisations put on school leavers expos to give information and advice about post-school options and other facilities and activities available for the person with a disability who's leaving school. Of course, increasingly young people with a disability can attend TAFE and university, and there may be special supports available for them to do so. If the disability needs and the disability support needs are changing, it is worthwhile considering requesting a review of the NDIS plan. And I understand that there have been some other sessions designed to give you more information about some of the processes involved with the NDIS. You may also want to consider photo ID for the young person and their eligibility for voting, and encouraging their carers to consider these issues. Next slide, Jenny. I just thought this was a wonderful slide of some young people having a great time out together, and that's the sort of activity and inclusion that we would wish for all young people with intellectual disability. Next slide. So I'd just like to finish here by providing the contact details for the 2 specialised intellectual disability health teams, the one based in southeastern Sydney and my team Strides in Sydney Local Health District, and invite you to contact us if you have any concerns or questions, and particularly if you have patients who you think ought to be referred to our teams who have sufficiently complex unmet healthcare needs and require a comprehensive team assessment. So I'd like to end there, Jenny, thank you. And just see if there are any questions.
Okay, Jackie, thank you for your thorough presentation. We do have a question here. Do you have any thoughts around how we can support this client group to access education around personal relationships and staying safe, particularly in relation to vulnerability and the internet?
Yes, the internet is a significant challenge for many young people, not just those with intellectual disability. First and foremost, it is important to understand what abilities a young person has, what they can read and what they can understand. Understanding their cognitive level, as Adrian described at the beginning of this session, can help you know what sort of tailoring or individualisation of communication is required to support the education of a young person with intellectual disability. As a general guide, if someone has a mild intellectual disability, their general academic skills are likely to be typical of those in the upper primary levels. Somebody with a moderate intellectual disability is likely to have academic skills, including reading skills, of the early years in K-2 type years. And somebody with a severe intellectual disability is not likely to master reading skills or academic skills beyond the preschool level. That gives you a general guide as to the sort of language and reading skills they're likely to have. This Family Planning Association has many adapted resources, including videos, and they also often run some other training programs to support the education of people with intellectual disability or their carers or other professionals who may be supporting them directly. So again, I'd encourage you to go back there. There may be some psychologists in the communities or other health professionals who may be particularly skilled in sexual health issues or relationship issues for people with intellectual disability. And I know there are some in the inner west who identify with that particular skill set and area of interest. It may require quite a lot of repetition and specific direction, education and skill building around, for example, relationships. The circle of friendships can be helpful for clearly indicating in a very concrete way how somebody with an intellectual disability may relate to other people. For example, in the inner circle are their close family and their closest friends who they might hug or kiss or be with. In the outer circle, it may be the acquaintances who they come across in the general public, and they may be taught to wave to these people or say hello. And their friends in the middle may have a slightly closer relationship and they may go home with them, but not be as intimate as they would be with their closest family. Tools like that can help a young person with intellectual disability learn how to adapt and build safety skills with safe relationships. There's a lot that is available from the Planning Association. The internet is a challenge, as we all know, and it may be that specific protective devices to prevent access to some websites may be appropriate to use. Beyond that, it is important to help teach a young person how to recognise if they are feeling unsafe or uncomfortable with images or videos. I think we all know of the high risk of the internet and social media, and I think we need to take special precautions where appropriate. Thanks, Jenny.
Thank you very, very much, Jackie, for a very insightful presentation. Miriam, do you have any questions from your end?
We had one question, but I think you may have just answered it. I'll repeat it to see if you've got anything to expand on. Do you have any thoughts around how we can support this client group to access education around personal relationships and staying safe, particularly in relation to vulnerability and the internet?
Yeah, Maren, we read that. I think that was when your audio dropped out. So,
right, sorry.
No, don't apologise.
No further questions.
Okay.
Can I just add to that, Jenny? Accessing the community, children, young people and adolescents with intellectual disability do need opportunity to develop their own friendships and to go out into the community. They are very likely to need some added support depending on their level of intellectual disability. But getting out into the community and building friendships away from their parents with some of the strategies that, some of the activities that Philippa mentioned, helps normalise them and give them diverse range of opportunities. This is part of their skill building as well. So it is important that we discuss those with their parents, even if their parents are initially reluctant for the young person to participate in some of these community outings. Thank you.
Yes, it's very important. I think to a young man that we have in Cronulla, he's well supported by the community in Cronulla as he drops into every shop and says hello, and he's a Cronulla supporter, so he's had a lot of wonderful community support. So I think back to him actually. Thank you, Jackie. Do any of the speakers have any closing comments before we finish?
I just want to say, Jenny, I've really enjoyed listening to the other presenters, and just to stress that it really is about us all working together to support people with intellectual disability, recognising their special needs and ensuring they're included as much as possible in our health services and our general communities.
Yes, and to be aware of the new specialist intellectual disability health teams. We've got two within the Cesfton region, so one in Sydney Local Health District and one in South East Sydney Local Health District. And Central and Eastern Sydney PHN will be doing quite a deal more work in the future regarding intellectual disability. We're working in collaboration with the specialist intellectual disability health team. So if you have any questions about this presentation or the past couple of presentations, let us know. So I'd like to thank the speakers, Dr. Jacqueline Small, Dr. Adrian Keller and Philippa Cook for taking the time to present tonight. Thank you to everyone for